Good day, ladies and gentlemen. Hello, dear friends. My name is Vasily Rakhovi. I am the hand transplant patient and the founder of the Voice of VCA Patients from Innsbruck, Austria. Welcome to this interview. This time our guest is Professor Alexandre Lellouch, Director of the Vascularized Composite Allotransplantation Research Laboratory and an Associate Professor of Surgery at Cedars-Sinai Medical Center in Los Angeles. Professor Lellouch belonged to the leading experts and innovators in the field of VCA worldwide. Professor Lellouch, good day. Glad to see you.
Thank you. First, thank you very much for this invitation. I'm very happy to be here today.
Thank you. I'm very happy too. Professor Lellouch, let me begin our conversation with your current research. Uh, Previously, you were a co-investigator of the VCA laboratory at Massachusetts General Hospital. Today, you lead your own VCA research lab at Cedars-Sinai. Could you tell our viewers, please, what kind of research are you working on now?
Sure, yeah, we moved our research lab from MGH to Cedars-Sinai. I took the lead of this lab, but I'm still working with Dr. Cetrulo. We focus on several research areas within VCAs. The key direction of my lab now, we focus on ex vivo machine perfusion, graft preservation, and subnormothermic machine perfusion applied to the whole eye and facial composite allograft. Bioengineered VCA, where we use deserialization and reserialization. We work on a Torrance induction protocol as well, and we work on mitochondrial targeted therapy to mitigate ischemia-reperfusion injury. So we know we have a lot of different topics because VCA is very complex. We need to work from the surgical side of the surgery to the immunological side and the reperfusion side as well. It's all of this is that makes this area complex is because we have to get multiple training from different specialties. For that reason, we're working with a lot of people in my lab. We have a lot of collaboration, and as maybe you saw in my previous publications, we work with a lot of scientists.
Yeah. Professor Lellouch, if you don't mind, let us talk about subnormothermical perfusion machine. As I understand, your research is a part of the human human eye allotransplantation program. Could you please tell our viewers how will the whole eye transplant program benefit from using subnormothermical perfusion machine? What does it mean in reality?
Yeah, it's a very good question. We have different type of machine from hypothermic, subnormothermic, and normothermic. Our choice taking subnormothermic machine perfusion came from because I started this area in 2016 with Corkut again. So I work on a lot on this, and we finally decided to take the subnormothermic machine perfusion. Why? First, we need to understand it's conducted at a room temperature is 21 degree. For us, it represents a deliberate compromise between hypothermic and normothermic approaches. Static cold storage, the current gold standard, is really inadequate for the eye for the eye globe because the retina and the optic nerve undergo rapid, irreversible degeneration within minutes without active metabolic support. Hypothermic perfusion suppresses metabolism but can cause cold-induced sterile injury, while normothermic perfusion demands a more complex setup with oxygenated blood-based perfusate and carries higher metabolic demands that are difficult to sustain ex vivo. So we decided SNMP for several advantages, mostly for retinal preservation. So we can maintain sufficient metabolic activity and support cellular viability while reducing oxygen consumption and metabolic waste accumulation compared to normothermic conditions. Basically, it's a balance, and we got very good results. We just published in artificial organ, this protocol on swine, on eye, and we maintained the eye for 18 hours. And actually, we made the cover of this journal. We're pretty happy for that. It's a good recognition for my team. But yeah, it's basically just to understand for us, it's a good balance between hypothermic and normothermic. It's for that reason we choose that.
Professor Lellouch, how will it change the way of performing the the highly complex reconstructive surgeries such as eye transplantation? Will it bring more time for donor matching donor options, or what advantages will this machine bring?
Yeah, every team working on machine perfusion, the main goal, I mean, there are different goals, but the first goal I will say is, extending the preservation time, so we have way more time to find a good candidate. Of course, depending where you live, if you live in Paris, LA, where we have a lot of people, is different, but some of our candidates live very far. And to find the right candidates is complicated. So yeah, if we have this type of technology, we can expand the logistical possibility. This extended preservation window could allow more time for HLA matching and cross matching, and expand the geographic donor radius, enabling transport over longer distance. So it provides a platform for graft quality assessment and reconditioning before transplantation. And one last thing about machine perfusion, it can serve as a vehicle for therapeutic interventions, delivering pharmaceutical agents, like gene therapy, and that is very important because for VCA, preservation is one thing, but tolerate this allo tissue, it's another thing. So in this technology, we can basically combine both preservation and reducing immunogenicity.
Professor Lellouch, let us go a little back in time. Has your interest in creation of perfusion machines for VCA come from your participation in the first facial retransplantation program established by Professor Laurent Lantieri at Georges Pompidou Hospital in Paris? Could you tell about your involvement in that program, please?
Yeah, of course. I mean, actually, I went into this field not actually in 20 because the transplant was in 2018, but actually when I was a med student, I was in the hospital for for the same transplant, but not its retransplant for the first transplant in 29. And I was there. I was a med student, so it gave me the motivation to go through this complicated pathway. So everything started there. And when the retransplantation arrived, I was a chief resident in 2018, and I actively participated because before this, I went, I did my research fellowship at MGH Harvard 2 years from 2015 to 2017. So when I came back from the US in France, this retransplantation happened. So I was fully involved in every aspect of this surgery, from the conception, the surgery, everything with Professor Lantieri and his team. So it took me a lot of time. I mean, I benefited a lot from this experience, still now actually, because only 2 retransplantation was performed in the world. It's very, very few. So yes, it definitely it was very formative for my interest in perfusion technology, because the retransplantation highlighted the critical challenge of graft ischemia time during this complex VCA procedure. At this time, we didn't use a perfusion machine. We used Hemarina technology as hemoglobin carrier from warm Arenicola marina we use that, not a perfusion machine. Basically, in the bag with the face, we put these worms because it's an oxygen carrier, and it works pretty well. In retransplantation, the surgical complexity is significantly greater than in primary transplantation, as you can imagine, because all the tissue are frozen, basically, from the previous surgery. The recipient's vascular anatomy is altered, requiring more proximal anastomosis, and the operative time is substantially longer. These factors amplify ischemia-reperfusion injury, and this clinical experience underscore the need for a perfusion system that could maintain graft viability during prolonged procurement and inset. This ultimately motivating me and my team to develop a very powerful perfusion machine. We're still working on it, actually, because when you work on this type of technology, it's not only you, it's your team.
Yeah.
You have to train your team. Only you, I mean, makes no difference, right,
Yeah.
for patients.
Yeah.
But the whole system needs to be trained, and it's for that reason it takes some time to spread this technology, because knowledge is one thing, but giving this knowledge to other people, it's another thing.
Yeah, you're absolutely right. Professor Lellouch, you are the author of the research paper about that retransplantation program that was published a few years ago. Maybe you remember that article? Could you please outline the key aspects of that clinical report? Especially, I would like to ask you about the use of antibiotics. For example, if the patient has an influenza, uh, do the antibiotics uh, cause variations of immune suppression level and lead to rejections or not? I think this question is very essential for every transplant patient.
Yeah, sure. First, I have a big thought of this patient. He died 2 years ago. I know his mother, and it was a very. This patient really changed my life. The way I see research and the way I see, what I'm doing. And I already have a thought of him because it changed. He really changed my life. This patient. Sometimes you think doctors change patient life, but patients change doctors' lives too. That is very important, especially
Yeah.
for this surgery. So, this transplant failed due to chronic antibody-mediated rejection. We call that CAMR. That it's our worst enemy because we don't have currently a treatment. This is coming, the manifest as a progressive skin necrosis and ultimately skin sclerosis, sorry, ultimately necrosis leading to a complete graft loss within 12 months of onset. So for this patient, we have to, I think it's the first time we did that, like a real desensibilization protocol. You can take a look to the paper. It was a lot of treatment initiated 20 days before surgery to reduce donor-specific antibodies level from the transplant. This procedure was, of course, technically more complex, and the patient, because of all of this treatment, of desensitization treatment, developed severe infection, including norovirus, CMV, esophagitis, and aspiration pneumonia, treated with systemic IV antibiotics. Honestly, I was very surprised he was still alive after, especially the post-operative days. He was a very, very brave patient, I can tell you. Your questions regarding antibiotics can lead to rejection.
Yeah.
Actually, it's a very complex question, but I can give you my answer. Antibodies, antibiotics themselves do not directly cause transplant rejection. Okay. However, the relationship is indirect and clinically very important. Severe infections can trigger inflammatory cascades that may precipitate or unmask rejections episodes. Furthermore, certain antibiotics can interact with immunosuppressive drug metabolism. For example, some antibiotics affecting cytochrome P 450 pathways, essentially altering tacrolimus or cyclosporin levels and leading to transient under-immunosuppression, so after it can cause rejection. And we noted in our paper that intercurrent infection disease were amongst the potential contributor to chronic rejection observed in this patient. And you see, antibiotics not directly lead rejection, but is because of this effect on the inflammatory due to the virus plus the inflammatory virus plus it interacts with cytochromes in the liver, can decrease the immunosuppressive level. It's not direct, but it's indirect. So the response is yes. But of course, if you have a very severe infection, it's better to take antibiotics because it can save your life.
Yeah, yeah, thank you. Thank you. Professor Lellouch, you are a prominent plastic surgeon. Therefore, I would like to ask you about the natural properties of the face. Are the natural properties of a transplanted face similar to the properties of a standard face? For example, I mean aging. Does a transplanted face age along with its new owner or not? I mean appearance of wrinkles, eye bags, and so on.
Yeah, I mean, I'm doing a lot of faces actually in my clinical practice. I developed even new type of surgery with the Dr. Sadati, because aging basically is you lose fat and it's fat displacement and it's ptosis basically. So we can expect the same thing from our VCA patients. But for facial, actually, it's different from normal aging. I would like to quote a study from Brigham, where they analyzed 3 full face transplants for 14 months using serial CT imaging. So this is from POMAHAC team. And all 3 allografts sustained significant volume loss, around 20%, actually, 19.55, between 6 and 36 months post-transplant. And we have the bone and the non-fat tissue volume decreased significantly to around 17.22%. So the response is yes. When you have a VCA, you age faster. That is a fact. You age faster, and even it affects everything: the skin, the muscle, and the bone. The 3 different layers, basically, of the face. We can understand that because basically, when you transplant the full face, everything is vascularized from, like with 2 or 4, pedicons, but it's still inflamed. It's still healing, right? It's and the body try to reject, even if you put immunosuppressive treatment, there are a fight, like an ongoing fight. Maybe with the treatment you can, mitigate the fight, but the fight is still there. So when you fight, you age faster, right?
Yeah.
And it's exactly what happened. I think that is my hypothesis.
Yeah, I understand what you mean. Okay, Professor Lellouch, and do the facial features of a transplanting face adapt to the recipient's facial features over the time? I mean, will the recipient look like as before the facial loss, or like his recipient, like his donor, excuse me? Yeah, I mean, I think this question is very important for the potential candidates for the face transplantation. I mean, how will the patient look like after the surgery, as he himself before the facial loss, or like his donor?
Yeah, it's a good question. Actually, every single face transplant is different. So some patient is partial face transplant, some patient is with the bone. For
Yeah.
example, at NYU, they use a 3D printer with cutting guides, and they took the whole bone for our face. I did 2 face transplants in France, but both transplant, it was not exactly the same surgical model. One was like a triangle. It wasn't reported yet, actually. And the other one with the retransplant, it was a full face, but it was only soft tissue. So if it's only soft tissue, it doesn't. I mean, of course, it always looks like the donor, but not that much because the patient takes the bony structure of the recipient, right? But if you graft everything, yes, it will look like more because the bony structure will be the same as a donor. So depending what you take, of course, if you take everything with the bone included, you will probably look like the donor. But if you just take the soft tissue, actually, you will have some, of course, uh, mutual features, but it will be different. You see what I mean? Basically, it's depending what you exactly transplant. It's not like hand transplant. Hand transplant, you have two main surgical models, but for the face transplant, you can take a triangle, you can take the full face, you can take with the bone, without the bone. And basically, yes, if you take everything, you will look like the donor, but if you just like partial part of the face, um, you won't look exactly the same.
Yeah, so it depends on the type of the face transplantation.
Yeah, yeah,
Partial,
exactly.
combined, yeah, or the full, yeah. Okay, thank you. Professor Lellouch, you have mentioned it eyelift grafting. Could you explain why is this part of the surgery most difficult one? And is the modern plastic surgery able to achieve this goal or not?
Yeah. I mean, eyelid surgery is very, very complex. We have a lot of
Mhm,
techniques to reconstruct eyelid surgery, even the lower lid. But the thing is, when you have the four eyelid affected, like the two, both superior and both inferior,
mhm,
you can't reconstruct that. You just can't, because the muscle is very thin, and you can't reconstruct that. So actually, even for the face transplant, the consensus for face transplant is when the orbicularis oculi and orbicularis oris are affected. When
mhm,
both are affected, you are a good, you're a good indication for face transplant.
mhm,
Allotransplantation is the most technically demanding component. We have a comprehensive review found that 54% of face transplant recipients receive allograft containing periorbital component. So more than half of the face transplant got the eyelid.
mhm,
The most common postoperative complications is a lower eyelid, ectropion, like this, ectropion, and lack
mhm,
of thalamus, and nearly all cases require revisional procedures. But with our conventional, it's for that reason actually we do some revision on our face transplants. It's mostly because of this area, because we
mhm,
transplant it, but usually we have some complications with ectropion or other issues, so we have to fix it. Right. It's for
mhm,
that reason we're doing revision of most of our cases of face transplant. When you do face transplant, the main goal is to be able to have a viable face, and after
mhm.
we can improve with conventional techniques. It's for that reason when I started this field, I was thinking, oh, face transplant is one-time procedures and done.
Mhm,
Unfortunately, it's not the case.
mhm. Yeah, so to say, achieving eyelids proper natural functions for opening, closing eye, protecting the eye is still remains a very, so to say, unsolved issue, as I understand. Yes?
Okay, just to be more accurate for that, modern plastic surgery can address many of these issues through secondary procedure. Okay, like, as I said,
Yeah.
cantopexy, tarsography, eyelid repositioning, but achieving full dynamic
Mhm,
eyelid function,
mhm.
like voluntary opening, closing,
Yeah. Yeah.
protective blink reflex, this remains challenging. The key limitation actually is not only the anatomy, but
Mhm,
it's a motor nerve reinnervation because we can't really control that of the orbicularis oculi muscle because if you don't have a proper innervation, it's not
mhm,
working that well. I know there are a lot of research on advances, nerve coaptation techniques and neutralization strategies to improve the outcomes. So for
mhm,
now, it's not perfect. We have a ways to improve it, but I can't get, I mean, I can't tell you we control everything in this surgery.
Mhm. I have heard this is very important for the eye transplantation, achieving yes, the function.
Yeah.
Okay, Professor Lush, one of your main research area is also elaboration of bioengineered composite, vascularized composite tissue. As I understand, is going on about growing an artificial skin, but also about what? Could you please tell more about this research, please?
Yeah, I mean, this is very great field. I
Mm-hmm.
worked with Basak Wigan at Harvard. I started my research with her, and after I'm continued that at Cedars-Sinai. Basically now, we were thinking for years and years that if you take stem cells, you can grow an organs. Unfortunately, it doesn't
Mm-hmm.
work that way. It's very complex. So we have actually different type of technologies to elaborate external cellular matrix, and you put cells in it. Basically, you try to you try to cut the
Mm-hmm.
issues in few pieces. So the deserialization is you take a natural scaffold, you deserialize, and you try to reserialize with recipient cells to have like an immunogenic transplant. That is a big goal.
Mm-hmm.
Actually, it's very complicated because you need to know the strategy for reserialization. You can do direct injection, you can perfuse through the pedicle of the organ, you can do by imbibition. It's a very complex, and in the same time we have another technology. It's called the 3D printer with like the in vivo 3D printer. Uh,
Mm-hmm.
Biological 3D printer, and that it will be, I mean, in my opinion, game changing. But we still need more powerful 3D printer. It's coming. I'm pretty sure in few years we can build muscle, skin, everything through
Mm-hmm.
3D printer. But it takes a lot of optimization for this machine. And actually, deserialization of a natural scaffold is not to apply, but is to understand the vascularization of tissue.
Mm-hmm. So to say, you can grow up organs in labs, yes, and the patient will not need any suppression therapy
Exactly.
after the transplantation. Yeah.
Yeah, that is the goal. That is the goal, is to create this in the lab and transplant it back in transplant it back in the patient.
Mm-hmm.
Of course, it's definitely not for now. It's for that
Mm-hmm.
reason the whole field
Yeah.
of xenotransplantation emerged, because a kidney from a pig engineered with CRISPR-Cas9, we already showed it works on patient for a few months. Like a
Mm-hmm.
heart was performed, a kidney was performed,
Mm-hmm.
because it's coming from a living animal, so it's the organ works, right? But I think all of these technologies, transplantation, tissue engineering, all of these work in concert, and the best will win, right? I don't know
Mm-hmm.
yet who will win, but definitely we need both technologies.
Yes, you're absolutely right. Professor Lelouch, in one of your interviews, you have raised a very important issue. I mean, combination between science and surgical skills. Having, so to say, as I understand, having even perfect surgical skills are not sufficient for performing highly complex reconstructive transplantation and plastic surgeries. Uh, could you share your opinion on this matter? Could you tell more about your point of view on this question?
You're right. The thing is, if you lead this type of surgery,
Mm-hmm.
uh, you have to work with a big team, a multidisciplinary team with many surgeons, but not only surgeons, nurse, resident, psychiatrist, like a big team. That is very
Yeah.
important. And you have to deal with new technology as well. Like
Mm-hmm.
I love what the work of NYU from Professor Rodriguez, what
Mm-hmm.
they the whole eye transplant and
Yeah. Yeah.
the face transplant, which is they use cutting guys, they use very great technology, but
Mm-hmm.
what is important, what we learned from this experience is they were able to work with a lot of people for one patient. And that is very different. When I do a rhinoplasty, when I do a facelift, when I do whatever thing, I'm alone. I'm the only leader. I can be helped by assistant, of course, resident, whatever, but I control the whole surgery, right? When you do a face transplant, you have to put someone in the recipient team, someone in the donor team. So the main thing is to be able to work with people. And that is so important because for most surgeons, they learn how to work by themselves alone because we learn to run our practice and to run everything. But in this case, it doesn't work that way. It's for that reason, if you want to build a very strong program, you have to be able to not only in clinics, but in research too, because this field, I'm convinced you can do this transplant with no research. For me, it's not possible. I mean, for me, it's not possible because it's still an unknown field. You know, we have 20 years experience, but it's not perfect. Our patients still reject. We still have complications. We still have chronic rejection. So we need to do both.
Yeah, thank you, Professor Lellouch. That was a very open, educational, scientific talk. I'm very grateful to you for your participation in our patient initiative Raise Awareness about VCA. Thank you very much for your support in this way. That was a big pleasure for me to talk to you. Thank you very much.
Of course, my pleasure. Anytime, if you need other thing, I'm available anytime. Okay? Say
Yeah,
hi to everyone.
thanks a lot. Yeah, have a nice day. Yeah,
You
goodbye.
too. Bye, sir.
Yeah.